Speaker is Siskin from Albany and downstate. Alumnus of downstate. Yay, downstate.
Thanks, Al. I appreciate the invitation, and thanks everybody for sticking around. I know it's been a long day. So I would like to basically take it a step back a little bit. I think we've heard about some fairly complex cases over the past hour or so, and I think I want to recognize that a lot of people in the audience here are people who are interested in getting this service started at their institution and offering it to their patients. So I really wanted to let you know what we're doing up in Albany, which, contrary to popular belief, is not just wilderness north of the Tappan Zee Bridge. And let you know what we're doing and some of the lessons that we learned and some of the challenges that we've been facing. So if I can just figure this out. Where should I face? So I would imagine, like most people who were getting started, we got a phone call, I think it was sometime in January, February, that literally went like this. I was wondering if you know anything about CCSVI. I just had an MRV and I'd like to look at it with an interventional radiologist. And I explained to the patient that no, I didn't know anything about it, and I would look into it. Invited her to my office, we sat, we chatted for a while, and proceeded with a venogram. And I think it's been a very exciting 6 months. So familiar. Now, 6 months later, things have changed completely with us. So that was one patient in January. I'd say it started slow from January to about April. In about April, I think I spoke with one of my patients who's sitting in the front row, Denise, who we chatted for a while on Saturday. She ended up coming to see me a few days later. And Denise has a very significant internet presence. And so all of a sudden, our service became quite different. And 6 months later, we have since seen 81 patients for primary procedures. 67 of those patients have undergone angioplasty. 14 of those patients have undergone stent placement, either with or without angioplasty of an additional vessel. We've also done 7 secondary procedures. So 5 of those have been after their primary procedure with us, and 2 after a procedure done elsewhere. And the first thing I want to tell people is that there's definitely a learning curve to this technique. I think when we started, we were like most people. We said, no, we know we can put a catheter in each of these vessels. We know we can take pictures, we can see a stenosis, and we can treat it. Now, I admit, I felt that way when we first started, and now I think after doing this now for a few months and seeing quite a few patients, my attitude is somewhat different. I do not believe that a vein is a vein. I do not believe that this is the same thing as treating patients with a DVT and treating the residual stenoses in the lower extremity venous circulation. I don't believe it's the same thing as a dialysis patient where we're treating central stenoses or peripheral stenoses. This is a different entity. It requires a different technique and a different knowledge base in order to provide. Now, certainly that skill set is helpful, don't get me wrong, but I think this is a different breed altogether, and I think we need to respect that. And I think with experience and with input from others, at least in my case, significant input from Sal after his trip to Italy, our technique has really become more refined. So I want to take you through what we're doing. So we are now routinely accessing our patients from the left common femoral vein. We do that in response to Zamboni's technique. We are looking at the ascending lumbar vein for hypoplasia, making sure that there's continuity. We're also assessing the left common iliac vein for Materna. Now, right now, that's out of academic interest, is what I would call it. I don't think we're necessarily prepared to treat every patient that we're seeing with common iliac vein disease, and I don't think we're necessarily ready to admit that we know everything that we're seeing in the ascending lumbar veins, but I think it's information that we can have. This particular patient is quite a severe patient who we saw, who was airlifted to our facility. She has significant secondary progressive multiple sclerosis, and she was one of the earliest patients we did a left-sided approach with, and lo and behold, we saw a significant Materna syndrome. Now, this particular patient, I have to admit, we treated. We treated her primarily because she had a significant cubitus ulcer, and she was felt to be end stage. We felt that it wasn't going to hurt her to reestablish her venous drainage, and felt like we were doing something positive for her. But right now, we're not routinely treating that. We're just kind of making a note of it when we see it. We also go into the ascending lumbar vein. This is actually one of my favorite cases because when we started this patient's procedure, we did a left-sided venogram through a sheath. Our wire went right up along the left side of the spine, and I was certain we had duplicated IVC, and I was like, oh, look, check this out, residents and students, this is such an interesting case. And we followed up with a catheter just to see, and we were in a fairly sizable ascending lumbar vein which we then managed to advance our wire, which just kept going freely up into the hemiazygous vein and the azygous vein, and we ended up looking at the azygous vein from below, which was a little bit unusual for us. So I think understanding the continuity of these veins probably does add something. I just don't think we know quite what that something is just yet. I think we're kind of withholding judgment on that until we have more information. Now, once we have evaluated the pelvis and the ascending lumbar veins, we go up and perform, just like Sal described earlier, a non-selective injection at the confluence of the subclavian and internal jugular veins to get a sense of reflux. And then we try and selectively catheterize each of the 3 vessels that we're studying: the left internal jugular vein, the right internal jugular vein, and the azygous vein. And we actually like to do them in this order. Now, granted, sometimes the catheter just finds another one of these veins, but we have found from a technical perspective that it isn't always easy to advance balloons into the left internal jugular vein. So my sense is that if we can get there first and use that and treat that vein first, then we have new balloons that we're using, and it's just technically easier to pass balloons into the left internal jugular vein. Technically more difficult, it makes it easier to pass a new balloon into the internal jugular vein on the left. Now, when we obtain images of these veins, we typically are doing an AP and lateral view for the mid to upper portions of both the right and left internal jugular veins. We also tend to do an ipsilateral anterior oblique view for the lower part of the internal jugular vein. We think that opens up the valve and the ostium of the internal jugular vein well. For the azygous vein, we tend to do a steep LAO and lateral view now for our patients. I admit we didn't start doing lateral view. I think it's helped see the azygous vein, and I think, as Sal mentioned, there's definitely a pitfall in looking at these patients, because without doing a true lateral view, you're really not going to see the azygous vein as well as you should. We too use dilute contrast. Sal's going to speak after I'm done about the benefits of IVUS during that procedure, but for many of us without IVUS, dilute contrast can be helpful. It can help uncover some of the intraluminal abnormalities that we've heard a lot about. And I think this is just a particularly interesting case where you can kind of see right here a flap in this stented patient, which we can talk about later. But there's a small little kind of mobile piece of tissue right here, which may be a misplaced vein or some type of septum there. But the fact is that it was real and required treatment, because I feel it was actually the underlying abnormality in this patient for this problem. Now, interpreting the images has been, I think as we started, it proved to be interesting, because whether or not we all want to admit it, the venous anatomy of the neck and skull is something that most of us don't encounter on a regular basis. So understanding the anatomy is something interesting. So I think in this patient, I just want to make sure that everyone kind of knows what we're looking at. So my interpretation of this particular venogram here is that we're looking at the anterior jugular vein. If you look at the diagram over to the right, I think you can see that diagram is the AJV. And I think you can see that frequently our catheter falls into this vein in these patients. And it's probably because it's markedly dilated due to the problems that they're having in their internal jugular veins. But in general, when we see the guide wire go up, at least initially, along the course of the internal jugular vein, but then veer medially, we're suspicious that we're in the anterior jugular vein, and we obviously do a venogram to figure that out. So that's an example of an anterior jugular vein. This is an example of a facial vein draining into a retromandibular vein, which then forms the external jugular vein. I think you can see that right here, going up here and down under the mandible, and then coming down as the external jugular vein. It's important to understand this anatomy. It's important to know what we're looking at, what's normal and what's not normal, in order to understand the potential collateral circulation that's forming in response to the abnormalities that we're finding within the internal jugular veins. Of course, inevitably you're going to pop into the inferior petrosal sinus, so it's helpful to understand what the petrosal sinus looks like, going into the cavernous sinus, which can then fill the contralateral internal jugular vein, and we see that occasionally. It's also important to understand the entry into the posterior veins, the vertebral veins, as well as the condylar veins right here. So in other words, there's all kinds of things that we're going to see that in order to at least understand what we're looking at, it's important to understand the anatomy. The other, probably most important issue that we face in interpreting these images has been how we define a significant stenosis. And how does this change when doing these procedures compared to other procedures? Now, most of us with arterial experience understand that significant changes in pressure and flow begin to occur in an artery when there's a 50% diameter stenosis, which, again, as we know, correlates with a 75% reduction in cross-sectional area. The other obvious thing that we know is that arteries are not the same thing as veins. And therefore, I think the fact is we have to admit that the degree at which a venous stenosis should be considered hemodynamically significant is not really known right now. We're throwing out 50%, But the fact is that we're throwing out 50% based on our arterial experience. We're not throwing it out based on our venous experience, and we don't really know exactly the extent of the stenosis that's required before it's considered clinically significant in patients with MS. Now, this, I would imagine, this I will tell you, is a typical case. So here's a stenosis. I think this fits the criteria of a stenosis that's at least 50% severity. We went in here, we did an angioplasty. The stenosis, I think, was really good. Flow was rapid out of the vein. We were happy with that, and the patient had a significant clinical response after the procedure. But the problem is that many of the patients that we've seen have what I would consider to be mild disease. When that disease is treated, we are still seeing significant clinical improvement. Therefore, I believe that we do need to be more aggressive in treating these patients and not necessarily look for that 50% stenosis. This was a problem early on, because early on, again, I will tell you, we interpreted many of the initial venograms that we saw as negative, because we looked at these stenoses and saw that they were maybe 30% stenotic. You know, I don't know many of us that are going to start doing this and think that treating a 30% stenosis is important, but in retrospect, I think they are important and probably think that they need to be addressed. So this is what I think is a fairly typical patient as well. This is a young woman with relapsing remitting multiple sclerosis who presented to us. Her right selective venogram shows mild narrowing at the base of the right internal jugular vein. We dilated her, a little bit of an impression on the balloon. Really looks better, but I'm not going to tell you that it's dramatic. Clearly it was a mild stenosis that got a little bit better. I think you can see the same thing on the left. Sorry. On the left side, you can see mild narrowing here. Here's our balloon, a little indentation on the balloon. Again, indefinite improvement in luminal diameter, but nothing earth-shattering in terms of what we're seeing before and after the procedure. Here's our azygos.
Area size balloons there?
You know, I don't know for sure, but I will tell you that typically we're using, on average, probably 12 millimeter balloons at the base of the IJ. Certainly some of them are small, we'll go 10, some of them are higher, we'll go 14. We're not usually going higher than 14 in these patients. Here's the azygos vein. What I think we've started to see is this contour irregularity right in the azygos arch. It's subtle, but clearly you can see the difference before and after an angioplasty. Nothing earth-shattering. I'm sure that there are valves there, like we mentioned. The flow is slow, but it's more the contour irregularity, often scalloping here. It's very, sometimes difficult to appreciate, but this kind of mild contour irregularity, maybe a little bit of scalloping, and we're treating that. We're using 2 millimeter balloons there. I think that I wasn't happy using balloons that were 4 millimeters in length, because I felt that it really tented and stretched the azygos vein, and I was uncomfortable with that. So I think the 2 centimeter balloons are much more appropriate to use at an appropriate diameter. Now, the important thing about that case is her response to that procedure. So, I think that we don't ever want to lose sight of the patients that we're treating and the improvements that they're seeing. So even with that mild disease, this person now considers that treatment date to be her other birth date. And more importantly, she says, this is a brand new body for me. She feels the shackles of MS have eased up and she can move freely and not be exhausted. She's been diagnosed for 18 years and she's thrilled that this has brought up more relief than any drug has ever attempted to do. And that is what I would consider to be mild disease for this particular patient. So, that's angioplasty. And I think that we've been fairly aggressive with angioplasty. As I learn more about what IVUS can bring, I recognize the limitations and we're working to bring IVUS to our institution. But the fact is that we've been more aggressive in treating patients with angioplasty even in the face of mild disease. Do I treat everybody? No, I don't treat everybody. When flow is rapid, when I'm not seeing obvious reflux on selective venogram, and when I see no change in luminal contours as the vein is passing through the valve, then I don't treat those patients. But in general, we're treating more patients than we're not treating, right? Or more veins than we're not treating. I also believe that stents have a role for these patients. So I'm in agreement with the last patient, with the last person who spoke. However, I believe that there are very much certain circumstances that warrant consideration for stent placement. The first is an angioplasty-induced dissection, and we have seen that. Here's a patient with a more severe stenosis at the base of the left internal jugular vein, right here. We treated this patient. There was a significant waste on the balloon. We eliminated the waste with angioplasty, and I'm sure you know how we felt when we saw this picture with almost like a spiral linear filling defect in the vessel. Flow is relatively stagnant, which I can't capture on these images, obviously. But the fact is that we interpreted this as a dissection and didn't feel good leaving this patient with this finding, so we stented this patient. patient did quite well clinically, very pleased, doing well to date, no problems, and a good clinical response. I believe that's an appropriate indication for stent placement. Acute thrombosis is another setting where we feel that we have to consider stent placement. Here's a patient, had a selected jugular venogram. We saw a very large collateral vessel coming down alongside the jugular. We were wondering if this was a duplication, but a subsequent oblique view really showed that this was probably the superior thyroidal vein coming down, sending tributaries into both the right and left side. And so these collaterals can exist. We went ahead and then uncovered, with less of a contrast injection in the lower internal jugular vein, a severe stenosis or moderate to severe stenosis at the base of the internal jugular vein. We again treated this with angioplasty and really felt that it looked very good. We were happy with the result. She was happy, noticed some changes in vision on the table. Sent her home, and sent her at least to her hotel room, excuse me. She came back the next day for an ultrasound. The ultrasound showed that that had thrombosed. So we brought her back and the next day, so 2 days later, and we did our selective venogram of the left side, saw the filling defect of the clot at the base of the left internal jugular vein. We did try limited thrombolysis in this patient, also some angioplasty. Did not feel that it addressed the stenosis to our satisfaction, so we placed a stent in this patient, but made sure that the stent did not go any higher than this collateral to make sure that the patient had the collateral root intact should they need it in the future. Now, there are also, of course, as our previous speakers have mentioned, patients who will have refractory disease to angioplasty. You know, certainly we look for any improvement in the veins after angioplasty, and it's never our goal, despite the fact that I'm talking a lot about stents. Keep in mind that the stent placement have been the minority of our patients that we've treated so far. But I think these are the cases that tend to bring the most heartache and agitation to both the physicians and patients as the procedures are being performed and after they're performed. So I think it's important to talk about the more difficult patients that we're seeing. So there are patients who have refractory disease. Here's a patient, in fact, it was the same patient that we brought down who was airlifted. You can see here we finally made our way up into the internal jugular vein on the left. We did a selective venogram, and we saw a tight stenosis right here in the mid-internal jugular vein on the left. When we pulled our catheter down and looked from below with less of a contrast injection, we were able to see this very tight stenosis. Now, yes, it's in the region of the carotid bowl, but I really felt, based on seeing this venogram, that there was no way to just say that that stenosis was due to compression by the carotid artery, excuse me. And so we went in, we did an angioplasty. We saw that it hadn't changed after the angioplasty, so we went ahead and placed a stent there, and we were actually quite pleased with the result that we saw in this patient, and she has since made notable improvement and is actually receiving physical therapy right now, where when she came with us, she was bedridden in the hospital bed. We have seen, like our other speakers before me, we've seen this twisting, per se, in the azygos vein. Oftentimes we find that this does not necessarily respond to angioplasty. If that stenosis looked exactly the same after angioplasty with it when it did, we went ahead and treated it with a stent. We did ultimately angioplasty this, got it to look a little bit better. But we were quite pleased, and she's had very significant improvement in her clinical symptoms as well. Here's another patient with a stenosis lower in the internal jugular vein. Somewhat difficult to see, but with the delayed image, you can see right here, this is after angioplasty, right here, it was very irregular. Despite repeated attempts at high pressure balloon angioplasty, we could not improve the luminal diameter of this vessel, so we went ahead and placed a stent in this patient. Again, this patient has had notable improvement in her presenting symptoms. These are all examples of patients who had refractory disease after angioplasty, which I do believe is a classic indication for stent placement and remains an indication for stent placement in this patient population. Now, of course, restenosis is another place where we can talk about stent placement. We know, and has been mentioned earlier, that Zamboni's sort of restenosis rate as high as 50% in 18 months. I think we also know that, while I don't believe that this is the same thing as the other venous angioplasty that we're doing, we certainly know that a restenosis rate is prevalent in venous angioplasty. And I think that when we hear about a patient who is having recurrent symptoms after angioplasty, it's a difficult patient to manage, and I actually think it's the most difficult patient for us to manage. For us, the strategy for addressing restenosis really depends on how much time has passed since the initial procedure and on the degree of improvement that was experienced by the procedure by the patient in the first place. So in other words, if I get a patient who calls me and never experienced benefit and wants to be treated again, I am much more hesitant about bringing that patient back and being aggressive with them, as opposed to the patient who calls me you know, whether it's 2 weeks or 2 months later, and says, I felt great, you know, my symptoms were eliminated, they were improved, and now it's back. I know I've reached Restenosis, I need to be seen again. So we'll image those patients, and we'll see them again, and we'll be much more aggressive with those patients, since I have some idea that treating them in the first place helped them. So here's a patient who we saw, and if you're having trouble seeing, it's because it was mild. It was a mild stenosis right here. We treated him. Maybe it looked a little bit better, or at least I convinced myself that it looked a little bit better, but it certainly didn't look worse. It didn't look bad. The flow was good.
Gary?
Yep.
What you got, your call was that this whole issue of big versus smaller balloons is
I'm on the smaller balloon side. All right. I think I've just seen, you know, the cases I've seen and that I've showed you where I've seen dissections and I've seen things happen to the veins. I just think I'd rather err on the side of being more cautious, especially as I think knowledge in this area is what at best we should wonder. So I think staying small is, in my opinion, what we need to do. Anyway, looking at this, I'm saying it was probably 8. I don't have the exact balloon, but it wasn't much higher than that. Looked like we got a little bit of improvement. He went home, told me he was feeling better. He was starting to feel his feet. He had no pain. He appreciated everything. He thanked me for giving him a better quality of life, and he'll keep me informed of his progress. Then the next email came. I think we need to talk about the next step. I'm the same as far as my symptoms as I was before that I had the veins open. I think they collapsed. Fairly aggressive guy from down south, flew back up, got him in within a month later, and we had trouble with this patient because we were unable to get past the area that we dilated. So we were high. We got into all kinds of various collaterals. Right here, I think you can see we're just wherever we are, we're in some type of thyroidal vein there probably. Finally, we made our way up. We felt that we were seeing the sigmoid sinus here, and we then moved forward with treating him. And what we ended up doing was stenting him. We created our own stent, our own flare-type stent with multiple overlapping, gradually increasing stents. Dilated it, stented him there. He looked pretty good, except for what we thought was either inflow or thrombus, but at this point right now, I just felt like, screw it, I'm going to put another stent right there. So we put another stent there, and we treated him, and it looked good. We were happy with this. We also dilated down here and got a good response. There was good flow with ultrasound. He has felt better, but not completely better. He said he feels about 50%, kind of right in between where he was right after the first procedure and where he was before we started. So that's where he's at right now. Here's another patient that I'm showing because I think that people throw around the use of cutting balloons fairly liberally from what I'm hearing here and from what I've heard in other arenas. And this is a gentleman who lives out on the West Coast who was treated twice. The first time he was treated with angioplasty, he felt he had a good response. It came back. He knew he reached the nose. The symptoms came back. He went to the same place out west, which, by the way, he wouldn't tell me where he went. And he was treated with a cutting balloon. And he was treated with a cutting balloon all the way up here near the upper jugular vein just before it entered the sigmoid sinus. And we initially had trouble. Here was our initial venogram. We couldn't get very good opacification up north here. We eventually did manage to get a wire up into the sigmoid sinus. We tried to inject from above. Really didn't see much because everything just went into collateral vessels into the vertebral veins. We pulled back and did more of an injection right here. And I think what you can see is a really fairly destroyed upper internal jugular vein right here. Now, here's the sigmoid sinus coming down here into these posterior veins right here. So the collateral system that he had has remained intact, but the vein right here was functionally and literally occluded right here. So he came, he obviously flew across the country to see us. He wanted us to be aggressive. We first treated him with an angioplasty to 6 bucks. I didn't even ask him. And this was after, sorry, 1 second. I just want to say, this is it. Oh, it just exited. That's bad. Right? I think I need your help getting back here. Sorry. What I can do with this? I just don't have it on my monitor anymore. That's okay. Anyway, the angioplasty obviously didn't really help, so we placed a stent in him and felt that we didn't want to go much higher with the stent than right here. I'll tell you, it was very tempting to want to stent around the curve here, but my feeling was that I'm going to cause him bigger problems. I see the filling defect here. I understand that this is either intimal irregularity or it's residual thrombus, but the fact is that his collateral system has remained intact, and I felt that I was unwilling to go any higher for this patient because I was worried about jeopardizing the outflow from that side. Even though we did block and he did have free flow of contrast down to the other side, I was really unwilling to go much higher than the primary source of collateral outflow on this patient. So we didn't go any higher than that.
How do you do?
He's done okay. He said he initially felt better. He's only about a week out, so to be candid with you, I can only tell you what he emailed to me, after his trip was home. He said he feels the way he did after his first procedure, but he's kind of wait and see attitude right now. All right, so right now we've been recommending Plavix or Coumadin for patients after stent placement, and it really depends on the circumstances that the stent was placed under. Right now, if we're placing a stent